the video and all. Hi, everyone. Hi. Sorry, we are a little bit late, later than usual, and because of some technical issues. But we are live now, and with me is Dr. Kenny Cheng, consultant cardiothoracic surgeon. Hi, Kenny.
Hi, good evening.
Hi. Yeah, Kenny is a new addition to our SGMC doctor family. So since we are a bit late, we don't have too much of those introductory videos and all that. So we're going to go straight to your presentation. He's going to talk to us about heart and lung from the cardiothoracic aspects. And I think you all be enlightened, especially those of us who haven't dealt with cardiothoracic matters for many years now. So you want to share your slides, Kenny, and then we'll go over to you. Now, before I pass over, I just want to let you know that the discussion will be on Slido. I will post the Slido link a bit later at the bottom. You'll see. And also, there will be CPD points, so we will share the QR code later as well. Okay. So just stand by. So over to you, Kenny, if you can share your slides. Yeah.
Yeah, I actually tried to share my screen earlier. If you can activate that.
Yes,
Otherwise,
yes, I've got your slides there.
okay, then
Okay.
I will start my slideshow screen.
Yep. It's on
Okay,
now. Okay. Over to you, Kenny. I will remove myself. Okay.
yeah, sure. Good evening, everybody. My name is Kenny Chang. I'm a cardiothoracic surgeon at SGMC. Just a brief introduction about myself. I was previously in a few cardiothoracic units, places like IJN, University of Malaya, Sedang, and also the Birmingham Children's Hospital. So I've just joined SGMC a couple of months ago, and I'm very happy to share with you about a little bit about this cardiothoracic practice, especially in my practice. So, as we all know, cardiothoracic surgery is an expensive and labor-intensive specialty. It requires a lot of intensive care and also a well-coordinated teamwork. And as you can see from the photograph on your right-hand side, of course, it requires a whole lot of support system, and it requires a team. And without any doubt, the captain is usually the surgeon. The team is headed by the surgeon. But bear in mind that there are a lot of supporting casts to ensure the success of the cardiac surgery itself. You have the perfusionists, you have the cardiac anesthetists, and then you have specialized cardiac nurses, and then sometimes the cardiologists do come in and help do some transesophageal echocardiography in the operating theater as well. You see, so it goes without saying that you really need a really specialized and labor intensive setup to ensure the success of this program. So as we all know, cardiothoracic is a portmanteau of two words, which is broadly divided into cardiac and also thoracic. So it's sad to say that thoracic diseases are usually the neglected practice of a cardiothoracic surgery, because not much is being talked about it, and the main focus is usually in the cardiac practice. But bear in mind that there are a lot of patients that actually require thoracic expertise. Subsequently, I'm going to share with you what are the diseases that I'm talking about. But by and large, as you can see, cardiothoracic practice is divided into two main categories. And if you are to look into the thoracic cavity, which is separated from the abdominal cavity via this diaphragm muscle. This thoracic cavity houses two vital organs, obviously, in which you have the heart right in the middle, which is flanked by the lung tissues by the side. So I'm going to start the discussion with common thoracic diseases that usually end up requiring surgery, and also the conditions that I frequently deal with. So what are the conditions that usually require surgical intervention? First and foremost, it will be things like masses, thoracic masses, mediastinal masses, cancers. On top of that, I encounter a lot of pneumothorax, unresolved pneumothorax. And then instead of air being trapped inside the thoracic cavity, you can also have fluids and also pus being collected, which is also called empyema. And then if we are going to discuss about thoracic diseases, we can't run away from this lung cancer discussion, of course. And I also see a lot of patients with hyperhidrosis, which is a sweaty palm syndrome that come to me for a sympathectomy procedure. We're going to delve more into that later. So, as I've mentioned previously, one of the major component of thoracic practice is about mass, tumors, and cancers. And one of them is actually mediastinal masses. As you can see from this illustration on your left-hand side, right in front of the heart and also the great vessel, there is a potential space known as the anterior mediastinal space. And in this anterior mediastinal space house involuted organ, which usually gets smaller as you grow older, which is the thymus gland. But in a pathological state, this thymus gland can get enlarged and develop tumors, as you can see from the scans on the top photograph. This is actually a well-demarcated lesion, which is also a thymoma. But on top of thymoma, you can also have a host of other different types of tumors in the mediastinal space. On your right-hand side, you have a heterogeneous mass, which is a big and is also usually skewed to one side of the lung. And this is actually a teratoma, you see. And sometimes in this teratoma, you'll be able to see some bone tissues and also tooth within the tumor. And then at the bottom, this is another kind of tumor that can arise on the mediastinal space, which is also known as a lymphoma. And as a surgeon, there are a couple of things that we can offer for the patient. First of which is to resect completely if the tumor is resectable. Otherwise, in other situations such as the lymphoma, we can put in a scope or a camera and do a proper wet biopsy, and that will give you a finalized result for you to tailor-make your chemotherapy for the patient. Moving on to the next condition, it's also known as a pneumothorax, which is quite common. As you can see on your left-hand side, this is an X-ray of a patient with spontaneous pneumothorax. If you compare the thoracic fields on both the side, the left side seems to be more whitish, which is the lung tissue, the markings of the lung tissue. As you compare to the right thorax, you can see the lung tissues are all completely collapsed, and you have a translucent area, translucent zone, which is dark black. These are actually air being entrapped in the thoracic space. And if you are able to perform a CT scan, this is how it looks like. You have a dark area, which is all air, compressing on the lung tissue and causing a collapse of the lung. In this type of situations, we will usually insert a chest tube to relieve the pressure and draw out the entrapped air. And then with the pressure being relieved, the air will be removed and the lung tissues will re-expand on its own. But bear in mind, there's a proportion of probably 10 to 20% of patients with pneumothorax. The problems are not resolved by the chest tubes alone. In this kind of patients, usually a small procedure, surgical procedure, minimal invasive small procedure will be required to address the problem. What we do is that we usually put in the camera, which is also known as the wet surgery, with keyhole incisions, inspect the lung. Usually you will find a bulle or an air sac that has ruptured off, that's causing an air leak, persistent air leak. So by identifying the problematic lung tissue, you can insert a stapler and staple it off, and that will eventually solve the problem of air leak that's causing the pneumothorax. So besides air being entrapped in the thoracic cavity, you can also have fluids being entrapped. And these fluids being entrapped inside, and if the infection sets in, it will turn into pus. And at this stage, it is also known as the empyema. And the treatment actually varies according to stage. In early stage, it might be amenable to chest tube drainage. But if it's beyond 4 weeks, usually you need to do operation, thoracotomy, to perform a decortication of the entrapped pus. This is just to illustrate a CT scan of a patient with empyema, of how it looks like. A CT scan will give you information of the size, location, and relation to the surrounding structures. And this will enable you to plan your surgery, to target which intercostal space to concentrate on. And they will usually need a thoracotomy to open up the chest, relieve of all the collection, okay, and then wash out and re-expand the lung. And these patients will usually come out temporarily with a chest tube. Okay, moving on to lung cancer. Just some points about lung cancer. It's actually one of the commonest cancer in the whole world. The problem with lung cancer is that a huge proportion of patients are actually asymptomatic. And by the time they come and seek medical help due to symptoms, such as chest pain, coughing out blood, persistent cough, difficulty in breathing, they are usually already in the third or the fourth stage of cancer. So cardiothoracic surgeons usually are only able to offer surgery for stage 1 and stage 2 tumors. Once they are stage 3 and above, surgery is not the primary treatment. They will usually have to undergo induction chemotherapy or maybe a palliative chemotherapy. So this is just to illustrate the lung tissue. As you can see, the left and the right lungs are slightly different in anatomy. On the left lung, you have 2 lobes, upper and lower, and then on the right lung, you have got 3 lobes, upper, middle, and lower. So if you are to have a cancer growing on the upper lobe zones, what we need to do is to remove the whole upper lobe, which is upper lobectomy, and also at the same time perform a systematic mediastinal lymph node dissection for proper prognostication and also staging. And let's say if it's growing on the lower lobe, we have to remove the whole lobe and also a systematic lymph node dissection. And let's say if it's unfortunately growing right in the middle of the fissure involving both lobes, then unfortunately you have to undergo a pneumonectomy, in which the whole lung tissue will be removed. So if you are to perform a CT scan on these patients with lung cancer, this is how it looks like. They come in various shapes, sizes, and location. Some are bigger, some are smaller, some are more peripherally located, some are more centrally located. But by and large, the hallmark feature of a lung cancer is usually irregular borders. The mass is irregular and it's got pointed ends, which is known as the spiculated ends. These are the hallmark features of lung cancer. And in advanced stages, you can also see enlarged mediastinal lymph nodes from your CT scans. So moving on to another condition in which the awareness is not that great, but I see a lot of patients with this problem, is this hyperhidrosis problem, which is also known as the sweaty palm syndrome. As you can see from the photograph, these patients actually have this bothersome symptom of persistent sweating. Sometimes it can be very excessive till the sweat is actually dripping every minute. And in some patients, the axilla is more affected, and in some patients, the sole of the feet is also involved as well. So right up until now, we don't know what's the cause of this condition. Neither do we have an effective medical treatment for these patients with sweaty palm syndromes. You can try all sorts of medications such as a beta blocker. You can try Botox injection, iontophoresis dips, and whatever remedial action. But by and large, all these remedies are actually not very effective. The only effective way to address this problem and to solve it once and for all is to perform a minor surgery, in which we will put in a camera, a scope into the axilla, identify the sympathetic chain, and ablate it off. This is a simple, short procedure. It will probably take 10 minutes on one side. And once the sympathetic chain is ablated, the palms will instantaneously dry up on the operating table itself. Okay, it's very drastic improvement, very immediate kind of outcome. So this is the only definitive and effective way of handling this sweaty palm syndrome. So that's all for the common thoracic problems requiring surgical procedures. I've saved the best for last, which is the cardiac diseases. Why do I save the cardiac diseases for last? Because this is the most talked about specialty in our surgical practice, because it's glamorous, so to speak, and the only things you hear about is heart and bypass surgery. But that's not all. There are other things and other problems with the heart instead of just the blood vessels. What are they? Of course, no doubt, the commonest heart condition that require surgery is also these blocked vessels that will require bypass surgery. This constitutes around 80% of all cardiac surgeries in Malaysia, adult cardiac surgeries in Malaysia, 80%. And the second commonest heart surgery in Malaysia is actually valvular heart procedures. This constitutes probably the rest of the 20% of cardiac work in adult heart diseases in Malaysia. So as you can see, our heart has got 4 valves, 2 on the left side and 2 on the right side. These valves will usually require repairing, or if not amenable to repair, we have to replace the whole valve. And then on top of that, for me personally, I have retrained myself in another sub-specialty in congenital pediatrics as well. This is another ball game altogether. It's a specialty all by itself. We're going to touch a bit about that towards the end. So about coronary artery disease, as you can see, what do you mean by coronary artery disease? Is basically blockages, okay, and narrowing of the heart vessels. And as time goes by, you have a large caliber vessel of this becoming compromised by the build-up of plaques and cholesterol and calcium. So once the heart vessels are being narrowed down tremendously, it will cause a lot of problems to the heart because blood flow and the blood supply is basically compromised. You must be asking why this process is happening in human being. This is basically due to diseases that you hear every day. The common diseases such as diabetes, hypertension, smoking, high cholesterol levels, and also advancing old age. And it goes without saying that our most famous bypass patient in Malaysia is actually our Tun Mahathir, who has undergone this bypass surgery not once but twice in his lifetime. So should you have blocked heart vessels and coronary artery disease, they do present in a spectrum of presentation. What do I mean by spectrum? On one end, you can have people walking around shopping in Mid Valley, not knowing that they have coronary artery disease because they are asymptomatic. On the other extreme end, you can suddenly have someone collapse and die right in front of you, or in the soccer field, or while they're watching TV. This is what we call a sudden cardiac death. So this are the both extreme ends of presentation. In between these two extreme ends, there are people that will experience chest pain, uh, lethargy, tiredness, or reduced effort tolerance. Okay, and then they feel uneasy. They just don't feel well. They have shortness of breath. They have problem climbing upstairs, uh, and etc. and etc. etc. So, in a nutshell, meaning to say, coronary artery disease can present in a spectrum of presentation, not necessarily chest pain alone. Okay. So, if you are to perform an angiogram, which is the gold standard, it will delineate the disease and tell you the severity once and for all. This is the gold standard angiogram. As you can see on your left-hand side, you have a big, fat, juicy vessel, with contrast-filled vessel coming down. As you go down, trail down the vessel, it gets tapered off and it gets cut off, and then it reappears again. So these are the stenotic areas. You see, it's very obvious. And then on your right-hand side, this is a right coronary artery. Another example, fat and juicy proximal RCA. You know, as it come down, it tapers off. Okay, it gets narrowed, then it fills up again. So these are the narrowed and stenotic segments that is giving problems. You guys must be wondering how bypass surgery is being performed, because this specialty is not widely available in all healthcare centers. It's only available in big and established hospitals. And I have a short video to explain. You guys can have a look.
The heart muscle. After the anesthesia takes effect, the surgical area will be scrubbed with a special disinfectant soap and may also be shaved. The surgeon will then make a 6 to 8 inch incision down the middle of the chest. The breastbone is then separated, the heart sac is carefully pulled back, and the heart is examined. At this point, the doctor will remove the necessary graft vessels for the artery bypass. Most commonly, an artery from the chest called the mammary artery and/or a vein from the leg are used. However, an artery from the arm or wrist may also be used. Once this is done, the bypass procedure can continue. At this point, the heart will need to be cooled to keep it still. During this time, the heart will be connected to the heart-lung bypass machine. After giving a large dose of a blood-thinning medicine called heparin to make sure that the blood does not clot, the surgeon will connect the heart to the heart-lung bypass machine with a plastic tube. Blood from the heart is then sent to the bypass machine through this tube. The machine supplies the blood with oxygen and then pumps it back to the rest of the body through the other tube. While connected, the blood simply bypasses the heart and lungs, but still reaches the rest of the body. After being connected to the heart-lung bypass machine, each of the blocked coronary arteries will be carefully inspected. The surgeon will determine the ideal place to attach the new vessel or vessels. Usually, the vessel is sewn into an area below the blockage and then into a location in the aorta. When your heart resumes its normal function and can support your body with its own pumping ability, it will slowly be removed from the heart-lung bypass machine. Because everyone's heart is different, the time it takes to be removed from the bypass machine varies. If your heart is slow to return to its normal function, several options are available to help it regain strength. These include medication through your IV or electrical stimulation from small, thin wires called pacing wires to help your heart beat normally until your own heart's electrical system has recovered. These wires are placed directly onto the surface of your heart and will be left inside your chest during your hospital recovery. Usually, these are temporary and should be removed prior to your going home. But in some patients, the wires may need to be replaced by a permanent pacemaker. Several chest tubes will also be placed inside the chest to collect any fluid that drains into the spaces around the heart and lungs. These help to ensure that the lungs and heart are working properly. Lastly, the breastbone is brought back together with thick steel wire. This helps the breastbone to heal and prevents movement. The skin incision is then closed with stitches and a sterile bandage is applied. The heart muscle.
So that is just a short summary of how bypass surgery is being done. But in this recent one decade, the recent 5 to 10 years, there has been a lot of evolution and new techniques and new adjuncts in cardiothoracic practice. Namely this cardiac surgery. And one of the example is actually how we strategize the conduit usage and how we harvest the conduits. As alluded by the video previously, conventionally we will need to take a leg vein, which requires a big incision, long incision over the leg, from the ankle up to the groin. And this will leave a big scar, of course, and more pain. And as you can see on your right hand side, 2 photos, some of my patients are actually being operated on. Some of them, there's a new technique called the endoscopic vein harvesting technique, in which it will require only a 3 centimeter wound over the knee. And this will require some specialized equipments and scopes to harvest the vein for the bypass surgery. So these are some of my patients. And on top of that, there are a lot of discussion about other conduit strategies as well. Things like bilateral internal memory usage instead of one, and the outcomes that they have shown that might be better if you use more arterial grafts, and etc. 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 And one of the commonest question that I usually get asked, in fact, towards the end of the presentation, or as a consultation and things like that, is whether CABG better or as good or not as good as this stenting, cardiac stenting. So this is the commonest question that people will usually ask, when they need to consider whether to undergo surgery or not. So by and large, there have been a lot of extensive studies, research, prospective studies, historical studies, guidelines, practice guidelines, both the AHA and the ESC guidelines. What I can conclude is that in a multi-vessel situation in which you have blockage of 2 or more heart vessels, bypass surgery is always superior to cardiac stenting. That's the take-home message, the summary. In the multi-vessel disease, and especially the complex and diffuse diseases, bypass is always better in the long term. And just to highlight to you, there have been a lot of new changes to the practice guidelines as well recently, as recent as 2018. But in year 2019, they have refuted the superiority or the non-inferiority of this stenting in certain subset of coronary diseases. There's been a lot of debate and scandals in this Excel trial fair, cardiac stent trial. So you all can Google up and go into the details of it. I'm not going to go into the nitty-gritty details of it. So just bear in mind, in a nutshell, what I'm trying to say is that if you have a multi-vessel disease, complex disease, bypass surgery is always better than coronary stenting. So moving on, like I've mentioned just now, the second most commonest heart surgery is actually on the cardiac valves. As you can see, our heart has got 4 valves, 2 on the left side and 2 on the right side. And these valves can either become stenotic, in which it is narrowed, or it can become regurgitant, just like your valves at home in your piping system, or your tap, at home. And what do they mean by regurgitant is that the valves are not closing properly, it's not coapting properly, and it's causing a lot of leak to the preceding chamber. So I will try to repair these valves as much as possible. But let's say if the valves are not amenable to repair, then we've got no choice but to completely replace the valve. And if I would need to replace the valve, there are usually two types of valves to choose from: the tissue valves and also the plastic mechanical valve. And the valve selection largely depends on the age of the patient. And moving on, for me personally, I have retrained myself after I became an adult surgeon. I retrained again in pediatric congenital as well. If I'm to talk about this pediatric congenital cardiac surgery, is basically a very heart-wrenching topic, in Malaysia. Not only in Malaysia, in the whole world, in fact, because not there are not many people that are willing to take up this specialty and retrain and etc. because of various reasons, of course. And this pediatric cardiothoracic surgery is way more challenging, actually, more complicated, and their problems are not solved with one surgery alone. Most of the time they end up with 2-3 surgeries. And why do I say it's more complicated, more challenging, and more complex than adult heart disease? You take a look at this photograph, like this neonate, the newborn. It's just a size of an adult palm. So you imagine how small the chest and the heart and the vessels and the structures in the chest for this baby. It's just too challenging, and it's another ball game altogether. But what are the things that we usually hear about in the newspapers, in the media, that people seek out help for? The commonest, of course, is hole in the heart. And when you have a hole in the heart, there are various names, various designations, and depending on the location of the hole as well. You have the simple ones like ASD, VSD. The more complex one, you can have AVSD, tetralogy of Fallot, which is more complex. And then, of course, you have some simple problems such as a PDA as well. You need to get there. And the problems do not stop there. They have multiple complicated problems, which is beyond the scope of this discussion. And we usually clump it under one category of complex congenital operations. So with that simple sharing, I end my short presentation. And I'll pass the mic back to the moderator, Alan.
Oh, thanks for your great talk, Kenny. Great overview of cardiothoracic surgery. Let me share my screen here. Okay, that's the this is the Slido code, and if you can go to Slido at 1620375 and ask questions there, or else feel free to ask questions in the YouTube chat box as well.
Sure.
Yeah. Just to get the ball rolling, it's very nice to see your vein graft being minimally invasive now that it's just a tiny incision rather than a horrible long scar along the
Yeah.
leg. In my days when people just started doing bypass surgery in Malaysia.
Yeah.
What other sort of minimally invasive cardiothoracic options are there that you think could be increasingly used in cardiothoracic surgery in general, either for valve replacement or for even bypass surgery?
Yeah. There is an option, of minimal. I wouldn't say minimal invasive. I would term them minimal access surgery, because they are not less invasive. They are just as invasive, if not more invasive, if you are not careful. So I would term them minimal access surgeries. There is actually an option of instead of doing a sternotomy for heart surgeries, you can perform it via a thoracotomy. There's an option on that. So instead of approaching right from the center, you go from the side with a thoracotomy scar, and you will institute a femoral bypass, bypass via the femoral vessels. So that is one, but it's not widely available, and people don't really do it regularly. And then of course there are things like robotics, which is also in the experimental stage. So heart surgery per se, this minimal access technique is not as prevalent and as developed as like for abdominal surgeries is completely different.
What about the requirement for heart lung bypass? Do you see a reducing need for that with any new techniques in
Okay.
cardiothoracic surgery?
So you're basically asking about off pump surgery, off pump versus on pump surgery, I presume.
Yeah,
So
yeah, yeah.
yeah, during those early days when off pump came around, off pump has been this so-called the trend. People have
Mm,
been trying to embark on that and things like that. Uh, but there have been a lot of meta-analysis, studies and outcomes and cohort studies, randomized control trials that have proven that actually off pump and on pump there's basically no difference in the outcome. That's why with this conclusion, off pump surgery has actually dropped down tremendously, especially in the Western countries. Is
mm,
is is only off pump is not better than on pump. It is non-inferior. That's the conclusion. It's not inferior to on pump, provided that off pump is done properly. So it's not better than on pump. It's just not inferior. So with that conclusion, a lot of this, because these Western countries, they go by evidence based, their practice. So with this evidence, that so-called off pump technique has this interest has fallen off quite a bit. But there are people that's doing a lot of off pump in places like Japan and India, but they are doing off pump because of other reasons. In India, they are doing it for cost saving because they don't have to use the bypass circuit, and it's cheaper. You save the cost and things like that. And of course, Japanese being Japanese, they really challenge themselves and they like challenging stuff. That's why they are continuing to pursue this off-pump technique.
mm.
Yeah.
Yeah, I suppose maybe in India also, maybe there's a challenge for getting trained perfusionists and equipment and all that. I
Uh,
suppose
not
maybe,
not
yeah.
Yeah, that is also one of the reasons. But by and large, India is they're doing off pump just to save the cost of the surgery. You don't have to do this cardiopulmonary bypass. You don't have to institute it. You save a lot of consumables and etc. etc.
Okay. There's a question from Dr. Jack Wong. He wants to know about CABG without thoracotomy or sternotomy. Can you comment?
Then that is not called surgery. That will be PCIs by the cardiologist. So CABG, you have to access the heart via an incision, either with a sternotomy or a minimal access thoracotomy.
Mm.
So you do need an incision to access the heart. If you don't
Ever
want,
be ever a future ever possible endoscopic CABG, for instance?
then that will be like a PCI.
Mm.
That will be
All right. So not in a moment. And there's a question from cardiologist Dr. Harris. Now, are you using total arterial graft or mixed graft?
okay. I use a mixed graft. Standard CABG is always for me is one IMA, single IMA, and the rest will be made up of the vein grafts. And IMA you usually reserve for the most important heart vessel, which is the LAD, left anterior descending. But uh, let's say if I have a very young patient, probably less than 50 years old, I will take a bilateral IMA, and try to put in more arterial grafts and take less of a vein graft. And if required, a radial artery, but I'm not a big fan of a radial artery graft because the results are actually not that compelling. I think. Coming to that argument, the discussion about is it better to use more arterial graft? The jury is still up there, because if you refer to the studies and the patency between the arterial and the vein grafts, these studies are all ancient studies done in the 70s and 80s. In that era, comparing arterial, yes, they do have better patency artery at that time, but it's been so many decades. The techniques on how we harvest the vein graft is different. We've got better antiplatelets, and we've got double antiplatelets now. So you can't really say that the venous graft, the leg vein graft, is actually a substandard graft. Because those data and those studies that's been shown to be less patent than the arterial graft were done in the 70s and 80s. Historical studies.
Okay. For those of us like me who come from the 70s and 80s, yeah. I mean, we still learn that the bypass surgery is preferred if it is left main stem disease or triple or multi-vessel disease.
Yeah, like what
I'm glad it still holds. Yeah, it
still holds. What I've mentioned just now, if you have multi-vessel disease, which is 2 vessels and above, when you have 2 vessels blocked and above, and especially in a subgroup of patients who are diabetics, the stents don't last in diabetics. That's why diabetics, and then a complex anatomy with a diffuse disease, surgery is hands down anytime better than PCI. Because you end up, putting in a stent in a diabetic with a diffuse disease, they don't last. 2-3 months, you come in, you stent again. How many stents are you going to keep on putting in? Yeah.
I think there's even for those with stable disease, if I'm not mistaken, maybe the cardiologist out there can correct me also. There's more data that, doing PCI versus medical management for patients.
Yeah. So
medical management is just as good.
Management has evolved, so you have to individualize the treatment. It's not one size fit all kind of thing. You have to see the patient's age, whether the patient is diabetic, anatomy of the coronaries, and etc. And also whether the cardiologist is adventurous type or not.
Okay. Dr. Aris, there's another question. Any technical improvement on calcific artery from surgical perspective?
Technical improvement. So let's say if you have a completely occluded vessel, we will try to find a healthy zone, a healthy landing zone to anastomose. And we anastomose beyond the calcified vessels. We will choose a specific zone that is healthy for you to perform your surgery to anastomose. But there are situations when the coronary arteries are so bad that it's fully clogged up, and you don't even have a healthy zone to anastomose, a healthy landing zone. And in such cases, you have to unfortunately do an endarterectomy, and remove all these plaques and calcium. But endarterectomy is not a good thing, and it's not a good prognosticator, in fact, for the long term. So we try not to do it. We try to find a healthy landing zone. But if the situation forbids easy surgery, then we have to do an endarterectomy.
Harris asked whether you have a team or you work solo. I think that's what he means. Is that?
Usually we will discuss the patient among the cardiologist and of course the surgeon. Of course, in a government setting, the heart team, a multidisciplinary team is there, to meet every week and things like that. But in the private practice, by and large, we still discuss about the best approach for the patient among the attending physicians, the surgeon and the cardiologist, and also the cardiac anesthetist. We will come to agree what's the best approach, and also the timing of the surgery. But the cardiac anesthetist sometimes they will give input as well.
Yeah, but I'm sure there's a lot of discussion with the referring cardiologists and so on, isn't it? Yeah. It's always teamwork. I don't think it's purely solo. No patients now will come to you as I want to bypass.
No. They will weigh all options and
Yeah. Okay. Let me check Slido whether there are any questions. Apparently, there are no questions in Slido. What I'll do is we'll move on to the CPD QR code display. The QR code being displayed now is actually the one for Slido. So to claim your CPD point, you use the MMA app, but please you cannot. If you're watching with your phone, you can't scan it with the same phone. You always need to scan and watch on another device. Okay, so you either need two phones or you should be watching on an iPad or a laptop. Okay, so this is the QR code for points. So if you use your MMA app, you should be able to get points. Let's double check. You all get it?
Yeah.
Yeah. Works well.
Yep.
Got mine too. Yeah. Okay. So, any final questions before we let Kenny go? What is your bulk of your work, Kenny? In terms, I suppose it's bypass or
Bypass, valves, thoracic.
Oh,
To forget thoracic. Thoracic is always the neglected specialty. People don't talk. They have a lot of mediastinal tumors, mass, hyperhidrosis.
Yeah, I remember it is an unmet need in Malaysia. I think there was a social group in Malaysia called the Wet Hands Club, where people seeking remedies for hyperhidrosis
I
and
didn't know
sharing.
about it. Maybe you can add me into the group.
I don't know. I'm not a member of the group, but I came to know it from the social media as actually a Wet Hands Club. And I don't know. I think that time probably sympathectomy was not very widely available then. But now I think with improved surgical techniques and
With
minimally
the minimal invasive endoscopic approach.
yeah, that would be a good thing. Otherwise, it's very distressing, for patients. It's just very debilitated. We can't do.
They usually come to me at teenage years, secondary school, 3 from 4 onwards, because that's the time that you will start socializing, taking hands, dating, driving, going for exam. That's when they find it very troublesome to hold the pen, to hold the boyfriend's or the girlfriend's hand. They feel shy.
The girlfriend will ask, "Why are you so nervous?" How long does the sympathectomy last in terms of keeping the hands dry?
It lasts a lifetime. It's highly effective.
Okay, right. Okay, so that's another option for referral for troublesome wet hands. Okay, Kenny, thanks very much for your time, and I hope everybody enjoyed your overview of cardiothoracic surgery, as I have, and update us on some of the latest advances and techniques. So, thank you everyone for watching. Don't forget to, as they say, don't forget to hit the like button, subscribe, and notification bell, so you don't miss any more talks from SGMC and any other CPD events. So we're having at least one or sometimes two every month, okay? And that would go on to help you accumulate your 20 mandatory points for your APC renewal next year. Okay, so have a good weekend, everybody, and we'll see you in the next broadcast. So I'm going to end now. Okay, good afternoon.
Thank you. Bye bye.